right, so today we're going to do chapter 28 and 31, Perfusion 1. Okay, so by the end of this lecture, you'll be able to, we're going to study, focus on number 1 and 4 of the SLO. So we're going to be able to plan nursing care to administer medications for patients experiencing cardiac emergencies and plan nursing care to administer fibrinolytics for patients experiencing an MI. Okay, so we're really only going to talk about MIs. So this is chapter 28 and 31. All right, and remember, this is only MI and only fibrinolytics. Okay, so what is a heart attack? You know, I didn't really understand this when I was in nursing school until they explained it, but I always thought the clot was somewhere else. But when you think about your heart, don't think about the internal structures, think about the external structures. Your heart is still a muscle and requires blood flow and oxygen to the muscles. Okay, so the blood vessels still need oxygenated blood. So when one of the arteries or gets a clot in it, now your heart doesn't have oxygen and it's dying. Okay, that's the heart attack, is that clot somewhere on one of those main arteries. Okay, so we're depriving the heart of oxygen. The affected area becomes ischemic, which means it's dying from lack of oxygen. And then so as the myocytes begin to die in about 20 minutes, necrosis of the myocardial tissue release certain marker enzymes called troponin. And that's how we test to see if you're having a heart attack. We draw a troponin, and if you have those myocardial tissue damage markers, that's how we know you're having a heart attack. Okay, and that's how we measure it, because it goes up and then slowly it goes down. And based on the number, we can figure out where you are. So it's a large, like we know, it's a very, heart disease is a very prominent thing, and it's one of the most, it has a large number of deaths each year. So treating them with fibrinolytics. So fibrinolytics dissolve clots. Okay, so they are most effective when administered 20 minutes to 12 hours after the onset of a heart attack symptoms. So we also give these for strokes as well, and we'll talk about that a little bit after the MI, but they're no joke. Okay, they dissolve clots. That means all clots anywhere. So like the little IV you put in, that clot's gone. That's like keeping it from leaking at the site, gone. It dissolves all clots. Okay, so it's no joke, and we don't give it lightly. Okay, ineffective after 24 hours of the event. Potential to produce serious adverse effects, may be administered systemically for treatment of MI, pulmonary embolism, or like we said, a stroke. So the drug we give is alteplase. So alteplase is a fibrinolytic. It is for MI, stroke, PE, restores the patency of central venous catheters. Okay. Keyword central venous. Okay, so we're not putting this in like peripheral lines to make, like, because they have a clot in their line. We're talking about big IVs that are life-saving things. Central venous catheters, hemodialysis ports, things like that have gotten a clot in it. That's what we declot. We don't declot IVs in the arm. Okay. So it converts plasmagen to plasmin and then dissolves the fibrin clot. The bleeding, adverse effect, bleeding. We've talked about that, right? Alteplase dissolves clots. So you're going to bleed. They will bleed. Okay. From the IV site, from wherever you puncture them, if you give them any IM shots, if you put in a catheter, they might bleed around the catheter insertion site. Okay. So it might be internal. Intracranial bleeding is rare, but it can happen. Spontaneous ecchymosis, which is bruising, hematomas, so now we're swelling on top of our bruises, epistaxis, which is a nosebleed. Okay, so we want to avoid aspirin, anticoagulants, antiplatelets, and NSAIDs. I'm going to put an asterisk next to aspirin. They will avoid aspirin, but a lot of times when you're having a heart attack, that's like the first thing they do is they give you an aspirin. So we don't want to completely cross them out if they've had an aspirin. There's a very long checklist, and if you've had your Eliquis, it ain't happening. If you've got any of those contraindications we're about to go over, it's not happening. Okay, so but aspirin, I think, is one of those that it may teeter-totter on, depending on which formulation, when you took it, how long it's been. Okay, obviously we avoid the 3 Gs, garlic, ginkgo, and ginger, feverfew, green tea, fish oil, because they extend bleeding. There's no overdose treatment. Once you start bleeding and you're bleeding too much, it's too late. We will try to stop it. We will stop the infusion, but otherwise there's nothing. So contraindications, active internal bleeding. If you're actively bleeding, we're not going to make you bleed more, right? Menstrual cycles excluded. For some reason, they need to put that. All right, history of a stroke or head trauma within the last 3 months. That means you've had some kind of clot probably, or head injury. We don't want the intracranial bleeding to happen because then we can die, right? So we're not going to do that. If it's been 3 months, you're not getting it. Surgery or recent trauma, not happening, okay? Severe to uncontrolled hypertension, intracranial neoplasms, or an AV malformation, which is an arterial venous malformation. So that's when the arteries in a vein, they like do like this and become best friends and they get tangled in each other. A lot of times it happens like in the brain. So they're like touching each other. And if you bleed in that, you will die. So it means your veins and your artery in wherever the AVM is what they call it, are weak because they've been touching each other for so long, so you can bleed out. Okay. So administration alerts. Swirl, don't shake. You have to use it immediately after you reconstitute it. Okay. Don't give IM injections or start an IV after you've started the infusion because they're going to bleed like a lot. Must be given within 12 hours of onset of an MI and within 3 hours of a stroke. Okay, that's pretty fast. It is a weight-based drug. And it has to be an accurate weight. So if they come up with a stroke and they can talk, we're not taking their word for it. We're stripping you down. We're getting an accurate weight on the bed. Okay. Some people lied about how much they weigh. We don't trust them. I want an accurate weight. It's got to be a real weight. Okay. Even for a heart attack too, real weight. Monitor vital signs, monitor neurostatus, monitor for bleeding. Okay. So when we say monitor for bleeding, we don't mean like the IV is bleeding or they have a little bit of a nosebleed or their gums start bleeding. Okay, because they're gonna bleed. Like that's the whole point of the drug. They're going to bleed. What we mean is monitor for that horrible bleeding or the excess bleeding and almost hemorrhage. Okay. So when we start getting those extreme hematomas that are swelling and swelling and swelling, that's not good. The compartment can only take so much pressure. We got to stop. Okay. If we have, like if our IV site's bleeding, we're going to hold pressure. Okay. If it will not stop and it is not a trickle anymore, we need to stop the infusion, call the doctor. Okay. But if, and we're looking for, that's why we check neurostatus to make sure we're not having the intracranial bleeding. Okay. That's why we were going to monitor for their abdominal pain because when you start having internal bleeding, there are signs that they will talk about in level 4 about where you can look for bruising that will indicate certain, especially trauma type bleeding. But otherwise, it's going to be like a distended abdomen. It's going to be hard and it's going to be painful. Okay. We're looking for if they're starting to cough up blood. Now we're having a GI bleed. Things like that. Okay. We're looking for that extreme bleeding, not like just, oh, I cut myself earlier this week and now it's bleeding again. And I have a small trickle of blood because that's going to happen. That's not important. That's not a reason to stop it. A reason to stop it is I'm having a hemorrhagic stroke. I'm bleeding internally. Okay. If uncontrolled bleeding occurs, stop the infusion, tell the doctor, hold pressure if possible. All right. So other drugs we use for heart attacks, antiplatelets and anticoags. So we use aspirin. It's like the number one thing. We use it all the time. The biggest deal about aspirin is that it is the chewable. We do want them to chew it because we want it to work really fast and we want it to be absorbed in your buccal area. So we're not doing the enteric coated. We're not doing any of that. Okay. So it reduces the formation and enlargement of the clot. Okay. So that's why we want to use aspirin. They will give Plavix or Acrostat. I've never really seen, but I've seen Brilinta. I've seen heparin, a lot of heparin be given. Okay. So, the antiplatelets are a big deal. All right. And they want them heparinized. Most cardiologists want them heparinized before they go for a cardiac cath or PCI or whatever you want to call it, because we want that the whole point of thinning the blood is, number one, making sure the clot doesn't get bigger. But these aren't like the fibrinolytics. Okay, these don't dissolve the clots; they just thin the blood. But if we have, let's think that we have a vein and we have this clot, okay, and now the blood can't get to the rest of the rest of it. If we thin the blood, maybe it can squeak by, okay, and then we're getting blood to the heart. That's the whole point of the blood thinners. We want the blood to go around the clot and get to where it's going, okay. Nitrates used to reduce chest pain. I could care less if it reduces chest pain, because the pain is not going to kill you. That clot's going to kill you. As we remember, nitrates, they are vasodilators. Once again, I have a vessel, I have a huge clot blocking it. If I can make that vessel bigger, I can get blood flow to my heart. That's the whole point. I'm glad it works for the pain, but I'm more happy about what it does, okay? So we have to, even though we're not really going over all these drugs, you've had these drugs in Pharm 1 and Pharm 2, you're still responsible for knowing the side effects and things to remember with these drugs. So we remember nitrates are vasodilators. The biggest thing is hypotensions, headaches, no phosphodiesterase 5 inhibitors, right? No Viagra or Cialis. So if my patient's having a low blood pressure, I'm not giving them the nitrate. Okay, that's why I say I don't really care that if it works for pain, because if it was pain medicine and it was necessary, they would give it no matter what your blood pressure is. But that's not why we're doing it. We're doing it because we want that blood to go to the heart. I want that reperfusion, okay? Beta adrenergic blockers, your beta blockers, metoprolol, labetalol. I see these given a lot with heart attacks. So they reduce the myocardial oxygen demand, slow the impulse conduction through the heart, can reduce mortality if given within 8 hours of a heart attack. That's amazing. So that's why they give it, okay? It lowers your blood pressure, remember, lowers your heart rate. So we're monitoring those before and after administration, okay? We're administering it at the right time and at the right speed, okay? We're not slamming it into these people because we're usually giving all these IV because we don't want any PO meds if they're gonna go for a cardiac cath, right? ACE inhibitors. So these is like catapril or lisinopril. They can reduce mortality, but within 24 hours, if it's given within 24 hours. So we've got a little leeway. So this may not be the one we're in the ER, we're giving all the drugs before they go for their heart cath. This might be one after the heart cath, okay? Because it's 24 hours. So you have more of an leeway. Whereas the beta blockers, they usually give them before they go to the heart cath, because 8 hours goes really fast, okay? Because you don't know when they started to have the heart attack symptoms. Pain management, opioids. We give opioids for pain. Once again, we watch their blood pressure, monitor their respiratory status, their LOC. But the important thing about pain management is morphine. It's like the go-to one for pain with a heart attack, because it is theorized that it works a lot like beta blockers, that it can reduce the myocardial oxygen demand. It slows your heart just like beta blockers, lowers your blood pressure just like beta blockers, and it helps you relax a little. So that's another reason why we give opioids, not just because they treat the pain, but because of what they can do for the heart, okay? All right, and then we're into more perfusion related emergencies, okay? Fibrinolytics, we've already gone over these. We're just gonna go over them again, okay? So they promote the process of fibrolysis and clot destruction, convert plasmin to plasmin. They quickly restore blood flow to the tissues by blocked vessels. Greater success is delivered within 4 hours of clot formation. We've talked about what they're used for. This is chapter 31. This is all you need to know. Okay, you've already done it because you did it for the MI. It's the same process. No need to do anything extra. Okay. The only thing I remember that we'll talk about is how it's administered. So I remember in IV calculations, we went over how it's administered. It has a very peculiar way that it's administered. So know how to give it and when to give it, okay? Go over those IV calculations and things like that, because that's definitely testable material. But that's about it. And that's Perfusion 1. So 1 down, 1 to go. If you have any questions, put them in the discussion board. Email me if you need to. Otherwise, good luck.